Hello, my name is Shanil, and today I'll be talking about coronary artery disease, and my case study was Gary. So as you can see, Gary is a 68-year-old bank manager, 12-year history of hyperlipidemia, 7-year history of hypertension, obese for most of his life, and positive history for cardiovascular disease. And he also had a pack-a-day history of smoking prior to quitting 5 years ago. So now Gary presents himself to the emergency department complaining of substernal chest pain that he also felt in his neck, jaw, and left shoulder. He's short of breath, nauseated, blood pressure at 150/94, and his heart rate is 112. So a 12-lead ECG was performed, which showed that Gary had ST segment elevation and T-wave inversions in leads 1 to 3. He's then treated with aspirin, morphine, and oxygen. Blood tests were also performed, which revealed elevated levels of CKMB and troponin 1 in the diagnosis of an acute myocardial infarction was made. He's then scheduled for bypass surgery to restore coronary blood flow. In the days following, Gary is also enrolled in a cardiac rehabilitation program, which he successfully completes. 12 months later, Gary starts to experience shortness of breath and a racing heart rate during physical exertion, and is diagnosed with stable angina. Now, first question, based on the ECG changes, which vessels are most likely blocked, causing the acute myocardial infarction? So in any given ECG, an elevated ST function combined with T-wave inversions is always indicative of a myocardial infarction. Now this particular infarction for Gary was in the left anterior descending artery. Now ECG in itself is a very reliable and non-invasive method that detects blockages in certain areas of the heart with pinpoint accuracy. So as you can see, this diagram shows a typical reading of a myocardial infarction of the left descending artery. Now, when the ST elevations are present in the first 3 leads, it can be determined that there is a problem in the left branch of the arteries. When the T-waves are inverted, it can indicate that one of the valves are obstructed, and as such, the heart begins to compensate by bypassing and using the other valves for extra work. So this creates extra internal blood pressure, which may contribute to Gary's hypertension. So second question, describe the pathogenesis of coronary artery disease. In your response, make reference to Gary's risk factors and how they may have accelerated his disease progression. So common factors that can put anyone at risk for coronary artery disease include obesity, diabetes, a genetic family history, a positive genetic family history, hypertension, poor diet, sedentary lifestyle, and smoking. Now, given Gary's condition, it is obvious that he fits into most of these categories: obesity, a genetic history for heart condition, hypertension, sedentary lifestyle, and smoking before quitting. Going into hypertension, it has been shown that with patients with hypertension and established left ventricular hypertrophy, the diastolic blood pressure reaching levels of between 85 and 90, this has been shown to cause ischemic T waves without any symptoms of ischemia. Now, there are also several experimental studies which have shown the presence of certain genetic markers, certain substrates, which are indicative of a myocardial infarction. One of these genetic markers is creatine kinase, in combination with the MB isoenzyme. Now, CK in itself may not be present in any sort of ischemic condition. However, with the use of the MB, this helps in establishing that there has been a myocardial infarction, and this helps in the diagnosis. Cardiac troponin is another little substrate which is present during after a myocardial infarction. Now, cardiac troponin CK, both of these are independent of each other, but both are attributed to the diagnosis of an acute myocardial infarction. Now, as you can see here, that troponin is a great genetic marker in detecting myocardial cell injury and necrosis, as it is highly sensitive and specific to ischemic dysfunctions. Now, one thing to consider is that troponin 1 can be present in both cardiac and non-cardiac ischemic injuries. So cardiac injuries include coronary artery disease, arteriosclerosis. Non-ischemic cardiac injuries include autoimmune disease, direct cardiac trauma such as stabbing, and metabolic problems such as renal failure. Other factors into the pathogenesis of coronary artery disease include coronary artery calcification. This is when there is an excess buildup of calcium in the arteries, resulting in reduced vascular compliance, abnormal vasomotor responses, and impaired myocardial perfusion. Now, this hardening of the arteries that is very similar to arteriosclerosis is a precursor in detecting further stages of CAD. And finally, IIG4 is a relatively new branch of clinical conditions where these certain cells, these IIG4 cells, infiltrate certain organs and multiply, causing fibrosis, the hardening of the affected organ and surrounding areas. So when detected in the heart, it may cause such conditions such as a coronary aneurysm, a pseudotumor, wall calcification similar to CAC, and intimal thickening. However, the cause for these high levels of serum IIG4 cells in the target area is still debatable, as case studies showed differences in etiology. Now, this means that these IIG4 conditions can occur in the heart, it can occur in the kidneys, it can occur in the liver. Now, and there is research going into it trying to explain what causes these cell buildups to occur with no relative answer just yet. Now, the next question is outline the core components of a cardiac rehabilitation program. As a clinical EP, in which components could you contribute? The role of a cardiac rehabilitation program is to optimize cardiovascular risk reduction, encourage healthy lifestyle modifications and patient compliance, reduce cardiovascular disability, and promote an active lifestyle. Now, there is substantial evidence supporting the benefits of a cardiac rehabilitation program, including increasing a person's exercise tolerance and functional capacity to the point where they can return to work and engage in recreational activities. And this is essentially the goal of any EP, to make their patients come back to the point where they can come back to a improved quality of life and they can resume independent living. Now, the cardiac rehabilitation program combines physical activity with psychological counseling, so this requires a multidisciplinary approach. Now, within the program, an EP's job is to control the risk factors associated with the patient's condition. When this is done, the program can reduce mortality and morbidity rates within the patients. And neat little tricks that an EP can introduce to their patients include GPS systems for their clients to measure the distance traveled when they're doing any sort of walking or light jogging, biking, ECGs every now and again for just monitoring the heart conditions throughout the whole program, and also the introduction of smartphone apps that can save all their exercise progress This will help in maintaining their exercise adherence to the program. Now, the impacts of a cardiac rehabilitation program include increased self-esteem of the patient, increased self-efficacy and reduced anxiety, weight loss, improved sleep, reduced blood pressure. Now, all of these help in reducing the risk factors for coronary artery disease and all the other conditions that have been previously mentioned, which can contribute to the metabolic syndrome. Other things that the rehabilitation program can do is to improve a client's exercise quality as a result of an improved peak of VO2, and reductions in comorbidities such as dyslipidemia, diabetes, as well as an increase in physical activity and reduction in smoking. So this also builds positive behavioral patterns within the individual. Now, what are the treatment goals for a person with a stable angina? Describe key pharmacological interventions used for secondary prevention cases such as Gary and how they contribute to successful management. Now, stable angina is usually a side effect after a myocardial infarction. This is characterized by persistent chest pains and difficulty breathing brought upon by strenuous physical activity or emotional stress. Now, the aim of the treatment for stable angina is twofold. First point is to improve the prognosis by preventing future myocardial infarctions and possible death, and to abolish or minimize current symptoms. As you can see here is a chart of certain drugs and pharmacological interventions which help in reducing the stable angina. Certain drugs such as statins, ACE inhibitors, and beta blockers, they all help in reducing the blood pressure, the heart rate, and it also helps in the blood flow, which helps in treating the angina. Now, the other drugs such as nitrates and calcium channel blockers, they help in assisting the myocardial blood flow, similar to the beta blockers. However, with all these pharmacological interventions introduced, there is always a chance that the patient may be allergic or intolerant to one or more of these drugs. So there has been research going to another drug, an alternative drug called ranolazine. This drug can be taken individually or in tandem with the other drugs that have already been mentioned without any overlapping side effects. So this is very helpful for those with an intolerance or an allergy towards certain drugs such as beta blockers or calcium channel blockers. A drastic surgical procedure, the coronary artery bypass graft surgery, is another method in treating the angina. This is a very touch and go situation. However, the success rate of reducing angina and other myocardial infarction symptoms is very high, so it's an option. Coronary revascularization is also very beneficial when a previous heart attack has been detected. Now, percutaneous coronary intervention is a non-surgical procedure that is used to expand the clogged arteries and improve myocardial blood flow. This in turn will minimize the risk of angina and myocardial infarction. Now, what happens is that a balloon or stent is introduced into the affected artery and is inflated to help in the blood flow. This treatment has a high success rate in reducing the angina and the risk of heart attack, as previously mentioned. A possible side effect of percutaneous coronary intervention is microembolization. This is the erosion or rupture of a vulnerable atherosclerotic plaque. Typical consequences of this microembolization are microinfarct with an inflammatory response, contractile dysfunction, and reduced coronary reserve, which again increases the risk of a myocardial infarction, or to a lesser extent angina attack. And that is my presentation with all my references.